Very warm welcome to everyone listening today. My good name is Dr. Masood Khan, and today our topic of discussion is syndrome of inappropriate anti-diuretic hormone, SIADH. In this condition, ADH is secreted in the absence of any appropriate physiologic stimuli such as a decreased effective circulating volume or hyper-osmolality. The major causes of SIADH are disorders affecting the central nervous system or the lungs, such as cancer or infections, medications. SIADH is a diagnosis of exclusion which involves ruling out other causes of hyponatremia, that is, low effective circulating volume, decreased solute intake, cortisol deficiency, and severe hypothyroidism. SIADH is a clinical diagnosis characterized by hyponatremia, decreased plasma osmolality less than 280 milliosmol per kg, absence of heart, kidney, or liver disease, normal thyroid and adrenal functions, and urine sodium usually over 20 milliequivalent per liter. Patients with SIADH may have low blood urea nitrogen, that is less than 10 mg per deciliter, and hypouricemia, that is less than 4 mg per deciliter of serum uric acid level. So SIADH, these levels of blood urea nitrogen and hypouricemia, which are not only dilutional but result from increased urea and uric acid clearance in response to the volume expanded state. So the other causes, the central nervous system disorders like stroke, hemorrhage, infection, trauma, inflammatory and demyelinating diseases leads to SIADH. Pulmonary system involvement, infections, viral, bacterial and fungal infections of the chest cavity leads to SIADH. Malignancies, especially the small cell carcinoma of the lung, is responsible for SIADH. Drugs, including antidepressants, the SSRI, tricyclics, monoamine oxidase inhibitors, antineoplastics, cyclophosphamide, ifosfamide, methotrexate, anticonvulsants leads to SIADH like carbamazepine, valproate, lamotrigine, neuroleptics like haloperidol, fluphenazine, trifluoperazine, thiotixine. NSAIDs is another group leading to SIADH. Ecstasy, amiodarone, ciprofloxacin, opioid. Other important entities that leads to SIADH includes HIV, pain, post-operative stress, hereditary SIADH, and idiopathic SIADH. So these are certain entities leading to SIADH. Now, the symptoms and signs of SIADH. Whether hyponatremia is symptomatic depends on both its severity and acuity. Chronic hyponatremia, defined as lasting longer than 48 hours, is often diagnosed on routine electrolyte measurements. Patients are often asymptomatic as the brain has adapted to the surrounding hypotonicity. Mild concentration and cognitive defects are common, as well as gait disturbances are common. Acute hyponatremia, defined as lasting less than 48 hours, can result in marked neurological symptoms due to acute brain cell swelling and subsequent rise in intracranial pressure. Early symptoms include headache and decrease in attentiveness, which can lead to lethargy, disorientation, and nausea. The most serious symptoms included marked confusion and decreased levels of consciousness, vomiting, seizures, coma, brainstem herniation, and death. So, clinical evaluation starts with a careful history of medications, changes in fluid intake, whether there is polydipsia, anorexia, IV fluid rates and composition, and fluid output, whether there is nausea, vomiting, diarrhea, colostomies output, polyuria, oligouria, insensible losses of fluid. The physical examination should attempt to categorize volume status, water and fluid distribution. The next determination is why ADH is being released and conditions in which release may be halted abruptly. So the lab findings which we should go for, that is serum and urine electrolytes assessment, serum and urine osmolality. ADH levels are not measured in routine clinical practice, and urine osmolality is used as a surrogate for ADH activity. Urine osmolality should be checked not only at the time of diagnosis, but may be useful if checked serially during therapy. Bedside assessment of volume status is often insensitive. Therefore, a urine sodium may help differentiate between hypovolumia and euvolumia. Additional testing includes thyroid and adrenal function tests. It should be checked in any patient with suspected SIADH. Now, what is the treatment of a symptomatic SIADH patient having hyponatremia? In patients with documented acute hyponatremia, that is onset is less than within 48 hours, sodium can be corrected at the rate at which it fell. In general, the majority of cases are chronic and therefore need to be corrected more slowly to minimize risk of osmotic demyelination. Pseudo-hyponatremia from hypertriglyceridemia or hyperproteinemia requires no therapy except confirmation with clinical lab. Translocational hyponatremia from glucose or mannitol can be managed with glucose correction or mannitol discontinuation if possible. Patients with hypovolemic hyponatremia require fluid resuscitation with either balanced crystallite solution or normal saline. Data from 2018 suggest that ringer lactate solutions may be a superior choice for resuscitation over normal saline, particularly in ICU patients. The correction of the volume depletion will remove the stimulus for ADH and permit renal excretion of a dilute urine. Now, how symptomatic hyponatremia is managed? So, symptomatic hyponatremia includes seizures, confusion. It should be managed with hypertonic saline regardless of etiology. A relatively small increase in serum sodium of 4 to 5 milliequivalent per liter is generally sufficient to promptly reverse severe neurologic symptoms and decrease intracranial pressure. This can be accomplished most effectively by using boluses of 100 ml of 3% normal sodium chloride over 10 minutes, which can be repeated twice if needed. Each bolus might be predicted to raise the serum sodium by 1 to 2 milliequivalent per liter. In patients with less severe symptoms, an IV infusion of 3% sodium chloride, that is 2 milliliter per kg per hour, may be used. So, in symptomatic hyponatremia, the serum sodium level should be checked 1 to 2 hours apart. Another complication of hyponatremia in case of SIADH is osmotic demyelination. The demyelination syndrome is the result of overly rapid correction of serum sodium in patients with chronic hyponatremia, previously called central pontine myelinolysis. Osmotic demyelination syndrome may also occur outside the brainstem. Demyelination generally occurs 2 to 6 days after inappropriate sodium correction and presents with profound neurologic deficits that are often irreversible. Risk factors for osmotic demyelination syndrome include the severity of hyponatremia. Majority of the patients has sodium less than 120 milliequivalent per liter. Alcoholism is another risk factor for osmotic demyelination. Liver disease, malnutrition, and concurrent hypokalemia are risk factors for osmotic demyelination. The optimal correction rate for hyponatremia is debated, though consensus guidelines suggest a correction not to exceed 8 milliequivalent per liter in a 24-hour period. So, if rapid discontinuation of the effects of vasopressin are anticipated, particularly in patients who are at high risk for osmotic demyelination syndrome, prophylactic use of IV desmopressin acetate to prevent a water diuresis should be considered. In the event of overcorrection, free water with or without desmopressin acetate should be infused to re-lower the serum sodium to an acceptable level. Now, chronic hyponatremia. Fluid restriction is a cornerstone of therapy. Although if the urine remains concentrated, it can be difficult to adhere to a strict water restriction that will correct the hyponatremia. Other measures to increase free water excretion should be considered. Options include loop diuretics, furosemide, with or without salt tablets, the vasopressin receptor antagonist vaptans, and oral urea. Vaptans impair antidiuretic hormone action by inhibiting the vasopressin type 2 receptors in the collecting duct, thereby inducing a water diuresis. So, nephrology consultation should be considered in patients with hyponatremia of uncertain cause or in refractory or complicated cases. Aggressive therapies with hypertonic saline V2 antagonists or dialysis mandate specialist consultation. Consultation may be necessary with severe liver or heart disease. So this is all about our case discussion of SIADH and hyponatremia management, the acute hyponatremia management and chronic hyponatremia management. Thank you very much.